our meeting to order. We're now to do the roll call, please.
Buchan.
Here.
English.
Here.
McEvers.
Here.
Evans. Here. Wood. Here. Miller.
Here.
So today we have an emergency special meeting of the Coeur d'Alene City Council to discuss resolution number 20-0059, requiring the use of face coverings in indoor or outdoor public places with certain exceptions to help reduce the person-to-person transmission of COVID-19. First presentation we have would be John Ness, who's the Chief Executive Officer of Kootenai Health and his team. So welcome, John.
Good afternoon, and first of all, I wanted to thank Mayor Whitmire and the City Council for this meeting and the opportunity to share information about our current status and some of the challenges that we have. And let me just start by saying that actually I'm sorry that we had to be presenting this to you today. You know, in our nation, there is a public health system starting with the Center for Disease Control, Department of Health and Human Services. States have departments of health, and our region has a Department of Health. And so in addition to the many challenges you have as city council members in a growing community, this is very complex, and I just wanted to tell you how much I appreciate your willingness to listen to the information we have, and thank you very much for that. So, Mr. Mayor, did you receive copies of the letter from our board of directors and our physicians?
We just did, half hour, 45 minutes ago.
Okay. If you didn't, I have copies of that if you'd like. I'm not intending to read it, but it's important for you to know that I'm the CEO of Kootenai Health and I'm representing the organization, but our board of trustees unanimously supports mandatory masking. Remember, our board of trustees is elected by the community. And so far we have had 281 physicians sign off on a letter also in support. And by the end of the day, it'll be well over 300. So a vast majority of the medical staff. So if you need copies, I have.
Yeah, I'll take copies of that. Okay.
So I'm going to make just a few introductory comments and talk about how we got to this point. And then I have two colleagues with me today. Dr. Karen Cabell is our Chief Physician Executive, and she is involved in daily incident command related to COVID-19. And then Jeremy Evans is an Operations Vice President who's been also very involved in this since the beginning in mid-March. So they'll make a presentation to you. So by way of background, where are we at Kootenai Health? In the past 30 days, our status has changed for the worse. We think that we have significant issues as a community hospital and the hospital in North Idaho that serves COVID-19 patients. What's changed? We have an increased number of COVID-19 patients in the 5-county region. We have an increased percentage of COVID-19 positive test results. Most of our medical surgical bed capacity is full. There was one day last week where we had one bed available. We're facing staff shortages and employee physician fatigue. We are now into the 7th month of this pandemic. And as you know, there is currently no vaccine. So this will continue. Schools have reopened and the cold and flu season is right around the corner. So the circumstances are such that we really feel like we have a problem and we really need to approach this from a public health standpoint. And we need the help from the community. So the question then is, how did we get to this point? What are the decisions that were made? And actually, what are the decisions that were not made? And why has this escalated? So let me go through this real quickly, but I think the chronology of the decisions is very important for you to consider. So March 11th, the World Health Organization announced a worldwide pandemic alert for the novel coronavirus with no vaccine available. March 13th, Governor Little declared a state of emergency in our state. April 23rd, Governor Little announced his stage 4 reopening plan scheduled to run from May 1st through June 26th. And then we quickly moved through all 4 of those phases and reopened our state and our community. Late June through mid-July, COVID-19 cases started to spike in Kootenai County. Of course, that's the time of year with July 4th, significant numbers of seasonal guests, tourists, etc., a lot of activity. July 23rd, as a result of that spike, the Panhandle Board met and made a decision to require mandatory masking in Kootenai County. We then started to see a decrease in the number of COVID-19 cases. September 24th, Panhandle Health Board met and reaffirmed the mask mandate. And several days later, September 29th, 11 North Idaho legislators sent a letter to the Panhandle Health Board asking them to reconsider the masking mandate and change it to a masking recommendation. October 21st, Kootenai Health basically maxed out our inpatient capacity due to an increase in patient volume, not just COVID-19, but overall patient volume. And there was one day where we literally had 1 bed available. Then October 22nd, the Panhandle Health District Board changed Kootenai County's status to red. And the same day, their board voted to rescind the masking mandate. None of those that voted to rescind the mandate actually live in Coeur or Kootenai County, even though 2/3 of the population of the 5-county Panhandle area live in Kootenai County. And today, October 26th, the governor is convening a press conference. And I believe that it's quite possible that the result of that press conference is that he's going to announce that due to a spike in COVID-19 cases in our state, he's going to roll back the reopening to stage 3. So the issue is not just in Coeur d'Alene, it's not just in Kootenai County, it's in our state. So today, my colleagues are going to share some more detailed and important information with you. And once again, on behalf of Kootenai Health, I want to thank you for considering this and appreciate the opportunity to share this information.
John, are your staff okay as council has questions through the presentation? They can
Sure.
ask questions. Yep. I think Woody.
Yeah, just a quick one. When you got down to 1 bed, it wasn't all COVID though.
Oh, no.
So
we have 330 beds. A good portion of those are for women's and children's services, labor delivery, neonatal intensive care that we would never be able to use for COVID-19 patients. And then we also have a number of behavioral health beds that are specifically designed for behavioral health patients. The 200 beds is what we call medical surgical beds that could be available for COVID-19 patients, but they're also available for patients that are post-surgical. So when we said 1 bed, it was those medical surgical beds.
which is what you would use for COVID.
Yeah.
Okay.
And we also have a designated COVID-19 unit that we have created in the middle of all this so we can better manage those patients.
Thank you.
So,
Any other council questions for John? Thank you.
okay, thank you.
Thank you all for inviting us to come today and speak. I appreciate the opportunity. So my name is Karen Cabell. I'm an internal medicine physician. I've been in practice for 20 years and lived in the community for almost 4. I do practice as a hospitalist at Kootenai Health, but spend the majority of my time serving as the chief physician executive for the organization. John had touched on a little bit of the numbers about Kootenai Health. It's an organization that has grown substantially over the last decade. We have more than doubled our capacity for patients and have grown our inpatient bed capacity to 331 patients. In the last week, we were able to add an additional 31 beds to this medical surgical area of the hospital. We don't have the staff for those beds yet. Large employer in the region with over 3,500 employees, and we serve over 50,000 patients in our emergency room and have a large medical staff, over 550 providers now. Wanted to touch a little bit on the pandemic and then a little bit about coronavirus to explain why these social behaviors that we have are so impactful on the disease trajectory. So it was just December 31st of 2019 when the first pneumonia cluster was announced out of China. And the reason why it's called COVID-19 and not COVID-20 is that it was that last day of 2019 that it was first identified. It took them a week to do the sequencing to determine that it was a brand new or novel coronavirus. A week later, the first case was identified outside of China in Thailand. A week after that, the first case was identified in the United States that came from a traveler from China. A couple weeks later, the first case was identified in that nursing home in Kirkland, Washington. It wasn't recognized until a few weeks after that. And then the first case of community spread, so not coming from a traveler, was identified at the end of February, and that was in California. Our local experience here was that we were able to get our testing up by the beginning of March. We started the emergency room-based testing on March 2nd and the drive-up testing center March 4th. It was March 16th that we had our first community positive. That was an individual that had traveled here from elsewhere in the country. And then we had our first hospitalization March 22nd. Because of the statewide mandates, et cetera, we did not see much transmission in March and April and in May. We had done a tremendous amount of planning over that time. We said we rewrote almost every hospital policy, came up with all of our plans for where we would put patients on this COVID unit, how we would handle things in the emergency room. We turned off surgery. We did all of those activities that many organizations did. And then we waited. Our chief nursing officer, Joan Simon, liked to say that it felt like we planned for a really big party and nobody showed up. But then when July hit, we started to see community transmission in earnest and had our first real spike in the area. And since that time, we've had 316 hospitalizations and 77 of those have required critical care. And the most up-to-date data that we have from Panhandle is that we've experienced 73 deaths in this area.
Karen, can I ask?
Please.
So 316 hospitalizations, that's all COVID?
Correct. So the 316 patients with COVID have been hospitalized because of COVID.
Okay, thank you.
Today we have 35 at the hospital, and they range in age between the 20s and the 90s. And every decade is represented. So there's at least one in the 20s, at least one in their 30s, at least one in their 40s, at least one in their 50s, and so forth. And then we have 11 in critical care, and the age range of the critical care patients today ranges between 40 and 70, with every decade represented. So this is not just affecting local individuals that are old and frail, it's affecting the whole population. It is true that the majority of patients that contract COVID and develop severe disease and die are in the older age populations and have comorbid illness, but that's not there are individuals younger and healthy that are also affected.
So, excuse me,
Please.
I just want to make sure I read this correctly. Your number up here said 77 have been hospitalized, but you have 35 hospitalized right now
So since we started,
since we started.
yep, we've had a total of 316 patients that have needed hospitalization. And since we've started, a total of 77 of those needed to be in critical care.
And right now there's 35
Correct.
overall
Correct.
that require hospitalization. And
Correct.
how many of those are in critical care right now?
11.
Okay.
Okay, so just to talk a little bit about coronavirus. Coronavirus is not the same as influenza. It is a different class of virus. The coronaviruses cause respiratory illness and GI illness, gastrointestinal illness in humans. And prior to this COVID-19 coming about, there were 4 common coronaviruses that circulated every year, and those caused the common cold. There were also 2 highly pathogenic, so not good for you, coronaviruses. One was SARS, which was identified in 2002 in China, and the other one was MERS, which was in 2012, and that was identified in the Middle East. And they were different because they were very deadly. SARS had a mortality rate of 15%, and MERS had a mortality rate of 35%. What makes COVID different is that it's the interval between symptom onset and the maximal contagiousness is on day 0. Whereas with influenza, you don't become maximally contagious until day 2 after your symptoms started. And with SARS and MERS, you didn't become maximally contagious until about day 5 or 7. And so you were clearly sick, clearly ill, clearly had something with influenza, SARS, or MERS. But with coronavirus, COVID-19, your maximal contagiousness is either right before you develop symptoms or very early on. The other thing that we know about COVID is that individuals who contract COVID that subsequently end up getting sick enough to go into the hospital where they're really not feeling well, it takes almost a week for them to get there. So they have their initial symptoms, they get tested, they're positive, and then a few days goes by until they get sick enough to require hospitalization. Additionally, many people, it is very true, many people have no symptoms or it's a very mild illness, but it's that particular piece that is causing us to have issues with how it's facilitating this undetected spread. So if you have no symptoms or really mild symptoms, you're like, oh, it's just a runny nose, oh, it's just a mild cough, and then you go about your usual activities, and without any check in place, then it's causing a tremendous amount of transmission from one to another. And that explains that rapid travel around the globe where, you know, you had a really mild symptom and you got on an airplane, you had a really mild symptom and you went to a sporting event.
Karen, have there been any studies done as to why this thing finds some people more delicious than others?
I think it's going to be a long time until we have definitive answers on some of these questions, but it is felt to somewhat be related to the dose of virus that you get as to whether or not you get affected. If you have a small dose of virus in the air as you breathe it in, it just gets into your nasal passageways and causes a common cold. If you have a large dose of virus that you're breathing in, it makes it past the filtering mechanisms in your nose or your nasal passages all the way down into the lungs. And it's when it gets down into the lungs that people develop the manifestations that are causing the hospitalizations.
Kind of an overwhelming thing.
Yes, correct. And then, you know, individuals with impaired immune systems, you know, other health conditions, they seem to be more susceptible to having severe disease.
But you still can't explain why, for example, in one family, you'll have one person who goes to the hospital and then 4 other people in the household who test negative.
Correct.
We don't know why it has that behavior.
Correct.
And there's no conjecture, is it dietary, blood type, nothing like that?
I am not aware of any studies in that regard.
Okay.
Yeah, you know, it's that concept of being exposed to somebody who's less than 6 feet away for more than 15 minutes is felt to be the largest contributor. And so, you know, there are many families that aren't spending a tremendous amount of time in the same room together, or it could have been at, you know, whenever it was symptomatic the most. as to when they felt
But
the
we just don't
transmission.
know.
Yeah, we don't know.
I have a quick question
Yes.
before we leave that. You said the SARS recovery rate was 15% or
Mortality rate.
mortality?
Yes, so
And,
of everyone who got it, 100 people got it, 15 died.
okay, and so where are we at on this one, on COVID?
Yes, so great segue, thank you.
Sorry, I thought you were moving on.
Yes, so what we know is that most patients are asymptomatic or have mild symptoms, 80%. It's probably based upon studies, say in the Navy ship, where there were lots of individuals who were, had surveillance testing on. About 20% are completely asymptomatic. About 60% have mild illness, mild symptoms. And then another 20% do get sicker and feel quite unwell, very much like the flu, where you body aches, fever, chills, cough, respiratory symptoms. We know that 5 to 10% in the literature of patients who contract the disease end up in the hospital. 2.2 to 3% require critical care, and 1 to 2% of the infected patients die.
How are you treating them now?
So the majority of the treatment is supportive care. We do have medications that have been studied that we're using under the emergency youth authorization. So we're using the antiviral remdesivir. We're using steroids or dexamethasone as a treatment. We have some patients who have qualified for the convalescent plasma, and then they're receiving oxygen therapy. So almost everybody who's in the hospital is in the hospital because they need additional oxygen above and beyond what you can breathe in.
Have you tried vitamin C?
There are a variety of, there's no pushback on using vitamins for the treatment of the illness. And so those vitamins have been used in the inpatient setting. So since we've started testing, we've had 3,400 patients who have tested positive within the Kootenai Health system. And our numbers are that 9.3% have been admitted and 2.2% require critical care. In terms of the mortality, if you look at Panhandle's numbers, because they have the totality of all patients, whether they die in the hospital or die outside the hospital, within the Panhandle Health District, it's a 1.5% mortality rate. If in hospital mortality, we're at 0.7%. All right, so early on, we felt that having safe and adequate testing was a priority for the community and for helping us stem the spread. We do have the drive-up testing center I mentioned earlier. It's open 12 hours a day, 7 days a week, and includes everything from the actual swabbing. The lab is there on site to get things packaged. We have registration, security, and traffic control. The testing volumes have fluctuated over time. This shows what it's looked like since the beginning of March until the end of October. And to date, we've had 3,400 positive patient results. We do track the zip codes of individuals that we're testing. And of our positive results, 96% of those have come from the 5 northern counties, and about 92, 93% of those have come from Kootenai County.
Excuse me, what'd you say? Kootenai County?
Mm-hmm. Early on, we created a surge plan for our hospital capacity, where we basically segregated areas of the hospital for treatment of COVID patients and then treatment for the rest of the patients, which is the majority of the patients that we still serve. We transitioned part of our new 3rd floor tower into the critical care unit for COVID patients, and then have already moved, the red box indicates we're into phase 3, where we're working on double occupancy. So we took single occupancy rooms and transitioned them into double occupancy so that we could have more patients physically in the hospital for the surge. That 3 East COVID isolation unit has both critical care and medical beds. It's got a specially trained nursing team. We have dedicated hospital medicine physicians and critical care physicians. And additionally, we have an anesthesiologist or anesthesia provider on the unit at night as that extra set of hands to help out, because the primary issue with COVID patients is maintaining the airway. And sometimes these patients need to be placed on a ventilator, and you want to make sure you've got plenty of hands around to take care of them if they have a decline. Up on this unit, they wear their PPE all day long. So they come in the morning, put that tight mask on, the face shield, the gown, the gloves, and they stay in that PPE all day long other than for breaks and at lunch. We've had a supplies and equipment tracking process using a dashboard. This tracks just about everything. We've got the personal protective equipment. We're constantly monitoring and switching gears on what we're doing to make sure that we've got an adequate supply coming in. Our supply chain team deserves a huge medal in addition to all the frontline providers, because they are checking the various vendors daily, they're calling, and we've had to come up with all kinds of new ways to source equipment. The supply of PPE in the nation has not improved. Prior to this, everybody just used their allocation. So whatever you'd been ordering for the last 12 months was what you got delivered. And it wasn't until you were able to start consuming more that they would actually deliver more. So what happened was, when this all started and the consumption went way up in every hospital in the US, they didn't start delivering more to you, even if you asked for more of the personal protective equipment. And early on, when New York City and areas in the South were having flares, our allocation actually got reduced because it was being shifted to other areas of the country that needed it more. So it's been a real tricky process for the hospital to make sure that we've got adequate PPE to keep our staff and patients safe. We also track our ventilator supply and other oxygen delivery devices, medications, not just the antivirals or the steroids, but you have to have other medications that are necessary for patients in these situations, such as sedatives and pain medication. Just like you all have had a hard time finding Clorox wipes in the grocery store, hospitals across the country have had a difficult time making sure we have adequate cleaning supplies, and have needed to use different vendors in order to do that. And then we have added, as I mentioned before, another 31 hospital beds under the waiver so that we can take care of more COVID patients if the demand comes about. However, personnel to staff those beds is a real issue, and we have to make sure we're working on getting enough nursing personnel and others in order to take care of the patients that we're serving. Jeremy is up next, and he has more details on what we're doing on the hospital capacity side. So any other questions for me?
Sure, thank you. So if someone got admitted, your policy is now anyone who's admitted to the hospital is tested for COVID?
Correct.
Twice?
Pardon?
Twice?
No, they're tested on admission, and then they're tested again if their symptoms warrant it.
So if someone came into the hospital for a reason, say an infection, and they had to be admitted into intensive care or whatever you call it, and their test came back for COVID, is that a COVID intensive care patient, or is that an intensive care patient with COVID?
If they were admitted for something else, they still have to be, and then they turn out to be COVID positive, they still have to be moved to the COVID unit, right, because they could cause contagiousness to others. That is considered we're still counting that as a COVID positive admission. There are extremely few of those. The reason these folks are coming in is because they've got low oxygen levels and respiratory failure.
Then I just have a question. In this dashboard that you're putting together, if you have so many beds that are specific for COVID, then you have to have the PPE gear, the staff, the ventilators. I guess where I'm going is the simplification has been brought to me that, well, they can just move the patients to other beds, but that's not possible because you have to have the staff, the ventilators, and the critical care trained people. Correct. In order to care for those patients. So it's correct. Not just a bed-to-bed count. Correct. Is that correct. A fair assessment?
Yep. Yes, that is correct. And for every 6 critical care beds that you have, it takes about 25 critical care nurses to take care of those 6 patients. And so if you've got limited staff, it's very difficult to flex up.
Okay, thank you.
Christie.
Along that question, how has your staff been holding up when you need that many critical care people and they're being exposed? What's your rate of exposure for your staff?
Yeah, I think I'll hold that because Jeremy has a lot of detail about what we've been experiencing with staff illness and difficulty in getting adequate staffing numbers.
Thank you.
Any questions? Thank you.
Okay, thank you.
Good afternoon. Thank you for inviting us. I'm just going to share a few more slides, a few more graphs to show some of the numbers, and then finish with maybe some anecdotes about where we really are at and how we may be able to continue moving forward together. So as John and Karen both mentioned, one of the first things we did was create a testing site so that we could get the necessary tests to patients. 2207 is the address, and we have done over 43,000 tests to date. This graph represents those tests that came back positive. And you can see early on we had a few, and then in July and August we had a surge. And we saw a lot more positive cases being returned from those tests. Of late, we are climbing and again into another surge. We have had over nearly 3,500 positive tests through Kootenai Health to date. We watch that positivity rate because usually as that positivity increases, and you can see our 7-day rolling is at 15.5%. When that positivity increases, we usually see a lag by a week or two with additional inpatient patients presenting at the hospital. So certainly kind of in that second wave, if you will. This graph, the blue line, shows that average daily census for COVID patients only. So again, that first hump is again back in July, early August, and we saw as many as 35 at one point in time. The yellow line or the orange line is of those 35 or total admits, how many were receiving critical care level services on those dates. So you can see it's a subset, but you can also see that they are also climbing in this second surge. Today we are at 35 patients, 11 critical care. The gray bars, if you can see those, are the positivity rates from the previous slide. And again, you can see that in the first wave, we saw that increase in positivity before we actually saw the patients in the hospital. And likewise, we're seeing increasing positivity rates and increasing inpatients at the same time. We talked a little bit about our total bed capacity is 331 beds. 130 of those are for behavioral health, labor and delivery, NICU, kind of specialized patient populations, which leaves 200 beds for our general medical surgical patients, of which a subset of those would be our COVID patients. This is our percent occupancy for the month of October. We usually operate around this 80 to 85% range. You need a little extra capacity to accommodate the turnover in beds, the turnover in patients, and the admits from surgical cases and what have you. You can see we go up and down. The dips are typically associated with weekend volumes. They're a little bit less. But if you were to draw a progression line in here, you can see we've been operating in the red, or the purple as we call, on numerous occasions. Last week we reached nearly 99% of these beds were filled. Now that's both the COVID patients and the non-COVID patients. But remember, we have kind of normal, necessary medical care that we provide every day at Kootenai Health. Those folks who have heart or neurosurgical conditions or pneumonia or other conditions that require care. So we serve both. One opportunity here is on our designated COVID unit, we are beginning to use double occupancy in patient rooms to increase that bed capacity. That helps with the bed numbers, but we still need the staff and the resources to care for patients in those beds. We're not alone in the region. This table shows, this was from last week, that Holy Family Hospital, Sacred Heart, Deaconess and Valley all had a number of COVID patients and all had a number of patients in the requiring ICU care for COVID. The last column shows their bed availability, and this is usually in the 1s and 2s, maybe 3s occasionally, but ICU bed capacity is limited in Spokane. Likewise, in the 10 northern counties, we have a regional hospital group that gets together to talk about capacity management. Our critical access hospital partners, most of the other hospitals in northern Idaho are 25-bed critical access hospitals. They can care for a few COVID patients, but they don't have the level of critical care services that we do. So Kootenai Health truly is the critical care hub for the 10 northern counties in Idaho. Long-term care facilities have also had capacity challenges, and several of them have restricted admissions, which again puts a bit of a challenge for us at Kootenai Health because it creates delays in discharge of patients who may need that level of care. I wanted to talk about our staff. This may get to your question as well. We have over 3,500 employees. To date, through the pandemic, 132 of our employees have tested positive for COVID-19. The safety and health of our patients has been one of our priorities from the beginning. Of those 132, over 85% of them had traced back their exposure to a community transmission, which means outside of the hospital. About 10% were exposed by a coworker who may have brought it into the hospital, and less than 5% were actually exposed from a COVID positive patient during their daily care of those patients, which really reinforces that hand washing, masking, distancing that we use in the hospital has been working. It's been very effective for us. We are experiencing staffing challenges right now. Our staff are growing a little bit weary. We are also seeing higher absenteeism because our nurses, our staff are calling in because they have loved ones, a child or another family member who is sick. There is a national shortage of highly skilled nurses in critical care and specialty services, and every community is trying to reach out for these traveling nurses to supplement their staffing holes. We have approved over between 50 and 60 new positions for traveling nurses to help fill the gaps, and we've been successful in filling about half of those at this point in time. This is a billboard that you may see around town. We have got an amazing set of folks who work for us. We sometimes say that healthcare is a team sport. Our nurses, our physicians, our technicians, our therapists, our housekeepers, our clerks, our receptionists are doing just an outstanding job, but they are getting tired. They have been working open shifts, open positions, covering themselves from head to toe in PPE, and caring for our community. They are simply awesome, but they are tiring. All right. I wanted to remember you all that we are your health system. We are owned, in essence, by the community. We are open 24/7, 365 days a year. We do not close. Today, we will see hundreds of patients in our hospital, and we will see thousands of patients in our physician offices, our urgent care settings, our emergency department, and our other outpatient settings. This is one of our COVID patients. His name is Joe, and he allowed us to share this photo. But he could just as well be your neighbor, your family member, your coworker, your friend, right? And in our mission at Kootenai Health, we call out that we serve our patients one patient at a time, that personal level of care. Well, quite honestly, with the stresses of COVID right now, we are pretty much on a case-by-case basis as we get requests for admissions, new surgical procedures, etc. Last week, we had to deny over a dozen transfers from outlying areas, okay, to critical access hospitals and communities because of our capacity challenges. We also deferred a number of surgeries. These were cardiac procedures, neurosurgical procedures, abdominal procedures, necessary surgeries that we've deferred by days or maybe a week or two, but they are normal necessary care that is being compromised because we are so full with some of the COVID patients. We talked about the long-term care challenges. Our system is stressed, but we are confident that we can continue to work together within the community to help spread and minimize the spread of COVID and spread out the curve over time. Our collective actions working together are absolutely necessary to slow that spread. Hand washing, distancing, masking have been proven effective to do just that. So we appreciate your time. We hope that this information is helpful to you in your deliberation. And if you have any other further questions, we'd be happy to answer those.
I had a question. We've gotten, council and myself have gotten a couple of emails, and one of them had said that the reason for this surge is that COVID is a term for a virus that is any cold. And so this is one of these conspiracy theories that I wanted to debunk from an expert, is that, so they're saying, well, it's cold and flu season, and these numbers that we are seeing aren't necessarily just COVID, it's cold and flu and everything like that. Can you speak to that? Is that when we do the test, we are recognizing specifically COVID-19?
Yeah. The testing that we rely on is called a PCR test, a polymer chain reaction test. And that is
Jeremy, can you scoot close to the mic?
Absolutely, I'm sorry.
Sorry, it's just loud in here.
Absolutely. The testing we use through the lab is called a PCR test. It's a polymer chain reaction type test. It's basically a DNA level testing, and it is specific to COVID-19. And Karen could probably answer a little bit more in terms of the clinical ramifications. There's a variety of tests, but no, the numbers we're presenting to you in the cases are truly COVID patients.
Yes, the testing that can be done today with this PCR type testing is very precise, very sensitive and specific. We actually have what we call a viral panel, which can look for every different kind of influenza. It looks for the coronaviruses that are the common cold type, as well as others. So you can piece it out where you can determine if it's flu, if it's COVID-19, if it's a different coronavirus. And to date, at least through our lab testing, we've only had 2 patients test positive for flu this season yet. And we generally don't see influenza pick up until late November, early December.
And then the testing results are at Kootenai Health are just part of the picture for Kootenai County, because some of them are going through Heritage Health.
Correct.
And
Panhandle, correct.
And for council's information, Laura and one of her staff members is here from Panhandle Health. If anyone has any questions specifically for Panhandle Health, she would be happy to come up. Go ahead, Dan.
So, Jeremy, right?
Jeremy.
You mentioned that, hand washing, social distancing, and of course, vitamins, eating healthy, being a healthy person, and masks. But this mandate is just about masks. Why? Why not mandate hand washing or the other things?
I think that is your decision and your deliberation. For us, nationally, right, the most effective means for slowing the spread is a combination of masking, hand washing, distancing, staying at home when you're sick, right? It's all of those things.
So in earlier, you mentioned, or Karen mentioned MERS and SARS. We also had swine flu in 2009. But yet, in all of these major outbreaks, there's never really been a push by medical professionals to mask. Why now?
I'll take that. I think we have not had a pandemic to this degree since 1918 with the influenza of 1918. And COVID has its ability to, the average number of people, if I'm infected, I on average can infect 2.5 other people. And with influenza, even the H1N1, it was less than 2. Once you go below 1, then the transmission stops. And
Talking about the R-naught.
Correct, yes. And
so we had SARS-CoV-1 back in 2002, which, if I got my numbers right, infected 60 million Americans. COVID-2 is now up to, what, 6 million Americans? And yet we still didn't, medical professionals did not mandate masking for COVID-1. Why are we doing it now?
So SARS-CoV-1 did not reach those numbers.
It didn't?
No.
Yeah, I think the current number, just throw it out, is about 9 million is where we're at for.
But COVID one did not, or SARS one did not reach 60 million infected?
Correct, it did not.
Any other council questions?
Just-
Kiki.
For either of you, I just want to be clear on this. The other hospitals that you're talking about around the county, they're small, 25 bed, or whatever the capacity is, but their critical care patients, whether they're COVID or not, would come to Kootenai first?
Yes, so there's only a couple of the critical access hospitals in our region that even have critical care units. So Bonner General has a critical care unit. They keep a few patients there, but if a patient needs a higher level of critical care, they need to come to Kootenai Health or to the Spokane area hospital.
That's for all the counties in the Panhandle.
Any other council questions for either John Ness or Jeremy or the doctor?
Sorry, I did have another one.
Go ahead.
And so you had put out a request for traveling nurses. This is in additional to your regular staff. And I'm imagining there's a short supply across the country. So you said you received half. You got half to supplement of what you actually need to support your staff right now.
Yeah, we've been able to fill about half of those requests.
Okay. But you're still looking? I mean, you're
Still
still
looking,
okay.
still short, yes.
Any other questions? All right, thank you.
I have one, just a quick one for Jeremy. So looking back and having an idea this could happen, when you guys did your expansion, would you have changed anything if you had a little insight that a pandemic could come and impact you guys?
It's a great question. When we built the expansion, we built it per code and through the state and there are guidelines on how many isolation and different airflow, et cetera. Yeah, we probably would have added additional isolation rooms within the facility. What we're doing now is we're designating an entire floor, which has its own air system. So instead of room by room, it's the entire floor, if you will. And we're partitioning it off appropriately when we have to float up or down.
Okay, and then the other question kind of along that way is how much elective surgery, everything was shut down for a while. Do we think of elective surgery as something that's critical, necessary, or I just want to fix my earlobe or something?
Yeah, I mean, I think it varies. What we have seen is that since we shut that down in early March, we have slowly been able to reschedule those cases and bring them back online. They are necessary. Okay. And further delay in certain cases can make their conditions worse. And we're seeing a higher acuity of patient right now as well. So I think we're feeling a little bit of a rebound from that shutdown period, if you will. And we are really trying hard to do what we call dual operations, which means we've got a designated unit for COVID that is isolated, that requires our staff to wear the proper head-to-toe PPE, but we also maintain our services so that we can treat the normal necessary, if you will, other conditions of care throughout the community.
Yeah, and last week when we were having quite the bed crunch, we ended up delaying or canceling 8 surgeries total. And they were open heart surgeries, neurosurgical cases, abdominal cases. So not something that you would consider elective, something that needs to be done. We just couldn't do it that day because we didn't have a bed for that patient to go to following surgery.
Thanks.
Go ahead, Ned.
So I don't want to correct myself. Not SARS-1, H1N1.
Oh.
60 million. There was no insistence by medical professionals to wear masks. Why not?
I don't know that I'm the best to answer that question. It did not reach the worldwide pandemic that this has.
But 60 million Americans had it.
Dan, and I don't know, but did you have any data? Was there data on deaths?
Maybe our folks from Panhandle could get a vaccine.
Yes, we had a vaccine.
How long did it take the vaccine to come out?
It came out in the middle of October.
Well, that helps me. What, again, the insistence upon masks and also just masking data, research on masks to mitigate the spread of viruses. There's nothing prior to March of 2020. Nothing. So why the insistence on masks now? You've already said you don't know how the thing works. How can, if you don't know how the virus works, how can you insist that a policymaker create a rule that mandates masks for something you don't understand. I mean, if I want to make a decision based on data, say that yes, definitely, we found out it's aerosolized, and if you wear a mask, you're just not going to spread it to anyone. That data, I've not heard that data.
Yeah, so masking has been used to prevent the spread of infectious diseases for a long time. It's standard practice in the hospital for patients who have influenza, who have measles, who have tuberculosis, any of those communicable diseases, for the healthcare workers to wear masks to reduce transmission. And that's actually been well studied.
I understand for healthcare workers because you guys are around it, but the general population, a 5-year-old, a 10th grader. We've had measles outbreaks. We've had whooping cough. That used to be the big thing. We first moved here. Panhandle Health would send out a notice that whooping cough is in the schools. Why didn't we mask up all the kids then?
The Centers for Disease Control and the other countries equivalent of that have studied the data and shown that it helps reduce the transmission. It reduces the amount of viral particles that get into the air that somebody else can subsequently breathe. And it's the universal masking, everybody wearing a mask, that reduces my ability to infect you, your ability to become infected by me, and vice versa.
Understand that, and that's new, but yet we have 100,000 years of human evolution that developed an immune system that's actually pretty good, given that there's like 4 billion of us on the planet at fighting these things. So what about the argument that people have offered me that said that wearing a mask actually harms you because all that stuff you're biologically designed to exhale is now getting trapped within you? I mean, is that legitimate concern for someone?
That is not a legitimate scientific concern.
No.
And
so there are no limits. A doctor in your hospital can wear the same mask for a 12-hour shift.
They are wearing the same mask for their shift.
They go into one surgery, you go into another surgery, same mask, another surgery, the same mask.
On the COVID unit. So if you're talking about a surgical situation or anywhere off of the COVID unit, it's single use personal protective equipment. On the COVID unit, because everybody has the same disease, everybody has COVID, then they wear the same mask for the duration of their shift.
So there's no real harm that could come to someone who's wearing a mask, who's exhaling whatever. It doesn't lower their oxygen levels. I've read that. It doesn't increase bacterial formation. It doesn't cause rashes on the face. None of that's true.
There may be rashes.
Oh, there may be rashes.
Yeah.
Okay.
But there's no evidence that it reduces oxygen level or it increases bacterial growth.
Would it also be true to say that the assumption of mandatory universal masking is that we all have COVID?
No.
Then why do it? I mean, isn't the result of it is that I may be asymptomatic and that I could infect you, and therefore me wearing the mask protects you, so the assumption is I have it.
The use of universal masking helps reduce the transmission and the disease spread within a community.
Assuming that everyone has it.
Assuming that everybody's wearing a mask.
But what if I don't have it?
I'm not sure I understand your question.
So your assumption that me wearing a mask is that I have it and that I could be spreading it. But I would assume, of course, that I'm healthy, and I don't know because I already had it, so I did have it. But if I'm spreading it, if I'm asymptomatic and I'm spreading it, then I'm wearing the mask to protect the community. This is an argument I've heard. Is that true? So I'm doing something based on a guess. I mean, it's kind of like saying that, you know, we're going to assume that everyone driving a car is drunk and treat them all that way because there are drunk drivers out there. Let's mask everyone and assume they all can spread COVID because there are a few people out there doing it. Is that the logic here?
Yeah, so we currently have, our percent positive rate in this community is at 17%. And so everybody
based on what? Based on just the testing you've done?
Mm-hmm.
Okay.
Yeah, the testing.
And that's not randomized testing. Those are people who volunteer to test.
These are individuals that have any symptoms or have been exposed.
So it's not randomized testing. Those are based on data.
Correct. So there's a high percent of people walking around that do not know that they have it.
Yeah, and I disagree with you there because that's statistically inaccurate. I mean, if I think I have it and I go get tested, but if I don't have it, if I'm asymptomatic, I need to wear a mask because I may have it. I may be spreading it, and I may have done that, unknowingly done it, and that would be bad. But yet, if you're just going to be testing people who assume they have it, that's a tainted sample. I'm sorry, I'm getting off into statistics. Could you have the gentleman speak? I think he wanted to address something.
Yeah, I think Jeff is going to speak to the universal masking.
Thank you.
Good afternoon. Thank you. My name is Jeff Lee. I'm the Epidemiology Program Manager for Panhandle Health District. And I just wanted to address a couple of questions Mr. Kukin had. As far as universal masking, we have not had measles in this area in quite a few years, decades, actually. I did have the opportunity to deploy to Washington, to Vancouver, to help them with their measles outbreak in 2019. They were using masking for people who were potentially infected going out into the community. All clinics were masking people, patients coming in, regardless of whether they had symptoms for measles or not. Now,
So
that
the
outbreak,
entire general population was masked?
no, those going into into clinics, or the reason for that, and I was about to address, is that there were 74 cases of measles in Cook County. That was it, 74 cases. We've had upward of 5,000 cases here. It's spreading quite a bit more than influenza, which is why we didn't use universal masking for flu. Although we did require people going into clinics, going into the hospital, coming into the health department to mask up. But as you recommended or suggested, it's the R naught, the amount of people on average that will go on to be infected from one infected person, much lower in influenza than it is with COVID-19. We're seeing more infection. With influenza, potentially you're infectious 24 hours before your symptoms start. With COVID, you may remain asymptomatic for the duration. We've known about COVID for 10 months now. We've known about influenza for at least 100 years, and much more studying going on there. So we have a better idea of the natural history of influenza. We're still learning about the natural history of COVID-19. We don't know the absolute number of people that are infected and asymptomatic. So we're not assuming everybody's infected. We're saying you don't know that you're not. We're asking that you take precautions.
Okay. Now, and I appreciate the information. I appreciate that you're an epidemiologist. So the R naught for COVID, I believe, is what, 2.3? Is that?
Best estimates are between 2.35 and 3.35.
And the R naught for measles is like 13.
Or like 17.
17. Okay, that's really bad.
It is really bad.
Okay.
You can, if I had measles, everybody here would be exposed, and everybody that came in here 2 hours after I left would be exposed.
And the mask would
catch the droplets.
Okay.
Prevent a lot of aerosolization. That's the purpose of a mask. The mask is to catch droplets and to prevent the further spread of the virus. The virus isn't alive. It can't fly. It takes a ride on the breath and on the droplets in that breath. If you're catching the droplets, they're not spreading. The reason that people change their masks is when they become saturated, then they become a superhighway for outside germs to get into them. So you shouldn't be wearing a saturated mask. You should be changing it out and wearing a dry mask. And the reason that physicians don't wear a mask from room to room to room, or between patients and surgeries or the same mask, is because they potentially have biomatter on their mask, on their gown, that they may take into another room. So it's a two-way street with personal protective equipment. It's not completely about protecting the wearer, and it's not completely about protecting others. It's both, protecting each other.
I appreciate that you're an epidemiologist. This is great. In the early days, they talked about masking in China, and then one of the doctors from Wuhan got the infection through his eyes. So is this a concern for the public?
It's absolutely possible. The virus likes to attach to mucous membranes. Your mouth and your nose aren't the only mucous membranes. Your eyes are also.
So why wouldn't we be ordering people to wear goggles?
We're having a hard enough time getting them to wear masks.
I'm just talking about the level of symbolism here versus a level of serious protection. So, I mean, obviously we can't issue everyone a hazmat suit. But if, you know, the concern of mine is the masking, doing it properly, the other things that were mentioned by Jeremy, washing hands, you know, staying home if you're sick. Is there anything that's done that would be effective regarding taking people's temperatures or measuring their oxygen levels as another way to determine whether you are, say, asymptomatic and could potentially spread the disease?
We found as the pandemic has progressed that temperature is not as reliable a marker of infection.
Interesting.
There are more subjective symptoms that occur that are more routinely identified, such as loss of taste, sense of taste and smell.
Very good, thank you.
Mm-hmm.
Kiki.
Thank you. And wow, Dan, wow. So I wanted to follow up with this question because it seems as though there was this parallel being drawn around these other diseases that you had mentioned, MERS, SARS. And do you know, sorry, two questions. One is, Kathy, I believe had said the difference is that this COVID is a new strain and it's a pandemic. And when SARS first came out, it was located in one continent and they did put out mask orders there and it didn't become a pandemic. Did I hear that correctly?
Yes, with some qualifications.
Okay.
SARS in the 2002-2003 timeframe was identified as a coronavirus. So it shares that with the current SARS-CoV-2. It did spread to multiple countries. We didn't have that many cases. I would have to look again, but I think we had 8 total cases in the United States. Canada got hit pretty hard, and I had the opportunity to talk to the director, Toronto epidemiologist, who was in charge of actually quarantining hospitals. Everybody inside stayed inside, everybody outside stayed outside. And she talked about it with tears in her eyes. It was bad. We did not get hit with SARS the first, that badly here in the United States at all.
So that's why we didn't mask up in the United States, because of the numbers.
Correct.
Okay.
But people were having their temperatures checked, coming into airports. With Ebola, we had people getting their temperatures checked, but with Ebola, temperatures were a much more common indicator of infection and an early indicator. That's unfortunately not the case with SARS-CoV.
We're still learning. Okay, thank you. I just wanted to clear that side up.
Christy.
Thank you, Mr. Mayor. Well, I appreciate the presentation, and my request is maybe you're already planning on doing this, but a lot of the questions that Dan asked, people are asking, and so he's asking the same questions. And my guess is that if you were to have a virtual forum, Mr. Ness, at the hospital presented that the community could log on to, you would get a lot of great interest, and I think there's a lot of value in it. So before you leave us, I was hoping that you would consider doing a virtual forum for the whole community.
I checked with my director. I'm from Panhandle Health District.
Oh,
by the
okay,
way.
I'm sorry. So just food for thought if you would consider, I mean, they can watch this presentation, but it would be really good if you maybe even had one on your website where people could click in.
I wonder if we could just
just take a minute and explain what's the role of the Panhandle Health District versus Kootenai Health? We are partners in this, but we are not the same organization. So the state of Idaho by statute creates regional public health districts. That's not Kootenai Health. That is the Panhandle Health, and it's comprised of the 5 counties of North Idaho. The board members are appointed by county commissioners. That is the entity by statute that is responsible for public education regarding all public health issues. We are a partner with Panhandle Health. They do a fantastic job, but we are a standalone community hospital. And so I just wanted to kind of clarify that, both important, but the public education responsibility associated with this rests with the health districts in our state.
Totally understand that. I think though that the stories that you've brought forward today are great to have that in the presentation.
Yep. As long as I have the podium, I'll just announce that as expected, Governor Little has made a decision to move back to stage 3 of his reopening guidelines due to escalating COVID-19 cases in Idaho.
Mr. Mayor. Appreciate you hearing and considering a mask mandate. And Commissioner or Council Member Wood, absolutely, whatever we can do to educate the public, to get the word out. We've been working towards that. Sure. And certainly I know the community is divided. Obviously the community is divided. But this is a truly important non-pharmaceutical intervention that we can do. The the other non-pharmaceutical intervention, other than washing your hands, social distance, masking, is the contact tracing that the health district does. And if we can encourage our community to answer that call, and if they don't want to answer the call, to at least contact their contacts and tell them they have been exposed. That is another way we can circle around this disease, and until we get a vaccine, stop or cease the spread. The more cases, I mean, it's simple math. The more cases we have, be they asymptomatic or symptomatic, the more are going to end up needing the care of our wonderful hospital. So certainly we work in all sorts of ways to educate the public. And we'll continue to do so. Mr. Mayor.
Mr. Mayor, you got a question? Go ahead, Dan.
Thank you. Thank you. So I was just going to ask you what the end game was, and I think you said you're going to wait for a vaccine.
Certainly, I'm hopeful that the vaccine is going to be efficacious and safe, and that it will create some herd immunity. So that's the current, I mean, originally it was flatten the curve and then get the numbers down, and now the goalpost is out to waiting for a vaccine. So this question, oh, come on. This question is, might be for Mr. Lee. Has there ever been a vaccine for a coronavirus that's been successful? We don't have a virus for the common cold.
Vaccine.
Or a vaccine for the common cold. There was not one for SARS or for MERS. Am I missing anything, Jeffrey? No, we haven't. This has been, as I'm sure you've heard in the media, this is unprecedented.
Right, so there's never been a vaccine for a coronavirus. Another thing that I've heard, so I'm passing along stuff that was sent to me. We got lots of email, at least 2. If you can get it twice, how does a vaccine work?
You know, as the panel of speakers has said, this is new. I mean, we're all in this. This is 10 months in. I think I was here speaking to all of you. I can't remember when. I mean, this whole year has been a blur. But months ago, we just don't know. And we will once we know. But this is brand new.
And again, this is a question that comes up. What is the efficacy of selenium in the diet with regards to fighting a virus?
And that I do not know. Jeffrey doesn't know.
Thank you.
Wait, Laura, thanks for being here. It's crazy. So trying to understand the structure, as Mr. Ness said, we asked for something. We're down here in the city level. You guys are not even in our city. I hate to tell you, you're across the border. How the structure, how you guys work? Your board said, nah. Yeah, you can stand here and say, yeah.
Certainly, it is the CDC recommendation that masks be worn. And we follow, and the board is strongly now encouraging the use of masks. The board is much like our community divided. And they did on 23 July, as Mr. Ness mentioned, come together and vote for the mandate. They met again subsequently in September and reaffirmed that. And this last month, it failed. And the reason one of the board members actually was just chatting with one of the board members prior to coming here, and his take on it, his rationale for voting no, as he voiced to me, was there's just no enforcement. So I mean, there's got to be more of a community, all hands in. I mean, it can't just be. We've got to have help from the lovely folks in blue.
So when you think in terms like that, and it's all on us right now, Coeur d'Alene, what about Post Falls and Hayden and Rathdrum, and we go on and on? And what's your perspective on that?
You know, I would be happy to chat with any of those mayors. I think that if Coeur d'Alene were to put forth an order, perhaps the others would follow. Perhaps not. I don't know. But people really need to take the order seriously, I mean, we ourselves need to take it seriously. I mean, I wear a mask everywhere I go.
So Laura, you and I talk quite a few times every week, and you know that I look at these cases, and the week of July 13th, we at that time had peaked at 323 cases, mid-July, and then we were on a downward trend. I attribute some of that to masking. We masked the third or so week of July, and we had a downward trend. Despite the fact that we were inundated with a lot of people from all over the country. I think that a lot of people from different places were used to wearing masks, whether it be from Washington or California, and they abided by that. So we're going along, we're on this downward trend, and then we're back up. First part of October, latter part of September, somewhere in there. And the latest number that I saw is that last week we were over, in 1 week's period of time, we were at over 700 cases, over 100 a day. So we've more than doubled what our high is from that mid-July point. Probably a variety of reasons. You know, schools is one. I think everyone's talked about the fatigue, the pandemic fatigue. But from your point, where do you think this doubling, and if we've doubled in a short period of time, if we've gone to 700, I've seen this grows rapidly, 700 this week, 1,400 next week, and who knows where it goes from there. But what do you see as maybe just a few reasons as to why this huge surge right now?
Well, Mr. Mayor, I think you touched on a few of them. Is certainly the COVID fatigue. I think people are just tired. I mean, we're all tired. Secondly, the weather is turning. I think a lot of folks were outside, and now people are going inside. Certainly, schools opening. You know, when we are seeing cases in schools, but again, kiddos, although they get sick, they don't, and they can spread it. I think it's so important that we keep those schools open, and whatever we can do to keep those schools going. I mean, the superintendents are, you know, they're struggling. I mean, they are trying to keep these kids learning and keep these kids safe. And whatever we can do to help with that, and if it is something as simple as a asking them to wear masks. I mean, it's the school board's decision. I understand that. I respect that, and always will. But the data, as the letter that Mr. Ness handed out to you, so from 300 physicians are telling you that these things work. Who else needs to tell you? I mean, these are our subject matter experts. These are the people that you trust to, open up your abdomen. And you're not going to listen to them when they're telling you to wear a mask. So, I think that back to the more cases we have, be they relatively, remember that 80-20 rule, right? 80% of the people are going to be relatively, maybe not even know they have it, very mild case. 20% are going to be kind of sick and feel not good. And of that 20%, 5% are going to go to the hospital because they're going to need some extra oxygen. They're going to need some help from those fine physicians and nurses. And of that 5%, 1 to 2% are going to need that ICU bed. And every one of those people matters. And our hospital capacity matters. As I think John mentioned, or Dr. Cabell, if you need to have neurosurgery, you want to have an ICU bed. Let's protect, and that's what this is all about, is protecting our hospital capacity. I mean, we're not just doing it to count cases. We're doing it to protect our regional hospital, Kootenai Health.
Now, I think in a lot of ways, we've just let our guard down is one of the things. I have been made aware of someone that got together, a family party of 18. Nobody was symptomatic. Nobody had a fever. Nobody had a cough. Of this 18, 14 of the 18 came down with COVID.
Right. It spreads like, if I'm in close contact with somebody for more than 15 minutes that has COVID, I have COVID.
Any other questions for council?
Just possible.
Oh, go ahead, Kiki. Or Amy, did you have? No. Okay, Kiki, go ahead.
Laura, based on John Ness's announcement, do you off the top of your head know what some of the masking requirements in stage 3 are that are different from what we're under right now?
There are no masking requirements in stage 3. The governor has never instituted any masking requirements. I haven't seen the order, but I think I understand it might be that it is having to do with a number of crowds, gatherings of more than, and I don't want to, I haven't seen it, but it's, he's put a number on gatherings.
Christy.
Mr. Mayor, I don't have any questions for Laura, but if I could address, if nobody else has questions. There's 3 areas that I want to focus on, but I'll take my turn. I don't want to do all the talking, but I'd ask you to come back to me. So the 3 areas I want to talk about: city ordinances and this specific ordinance, the mechanics of it. I want to talk about enforcement, and then I want to talk about how I'll make my decision. So if I could just start with the first one, and then you come back to me.
And then we can lead into enforcement, right?
Okay, yes.
And then we can have Chief White.
Yes.
Yeah.
Okay, thank you. City ordinances. I want to just in general talk about city ordinances. I have about 30 years of law enforcement under my belt, 26 years here in Coeur d'Alene, and I enforced a lot of city ordinances. I'll tell you about just some that you maybe aren't even aware of. You can't smoke on the city beach. You can't drink alcohol in the park unless it's a permitted event in a certain park. You can't shoot fireworks off in the city park, and you certainly can't on Tubbs Hill. Councils in the past came together and said, we have a lot of people that come to visit us. They like to bring those bottle rockets, and so we're going to protect Tubbs Hill from being a big fire danger. You can't let your dog bark all night. I've knocked on people's doors at 3 in the morning and said, Spot's out here barking. Everybody in the neighborhood hears him but you. And so people generally comply. They bring the dog in. Now, if I go back the next night, the dog's still barking, everyone's awake. And then you don't do warnings anymore. You say, here's your citation, press hard, make 2 copies, because what we're looking for is a change in behavior. That's for the betterment of that entire neighborhood. Other examples, you can't leave your boats and your RVs on city streets. Right now, if anybody's watching, please go move those boats and RVs so our city crews can get in and remove snow. These are city ordinances that restrict your movements, restrict your freedoms. They've been developed over time in the interest of public peace and public safety. I don't even talk about state and federal laws, which there's thousands, that are all revolving around the same kind of theme. So what's being proposed today, this would be a temporary ordinance. All those other ones that I've talked about, and there's a lot more I could talk about, those are permanent. And I don't think you're going to find a city council now or in the future that are going to go back and revisit and say, yeah, we're going to let your dog bark all night. Have at it. We're just not going to do that. If we put in place a mask mandate, my proposal would be, it's obviously temporary, it's written that way, it's a temporary proposal to help our community slow the spread. So with that, if we could talk about specifics of this proposal, Mr. Mayor, when we go through it, I don't know if someone's going to present it, if Brandy or someone's going to present it, and then we could offer amendments.
I think that Chief White will invite Chief White up, and he is going to share a few words, and then Wes Somerton was also
Okay, thank you.
talk on that.
Good afternoon, Mayor and Council. Yes, I was asked to come and just speak briefly about the enforcement aspect of this, what this really would mean for law enforcement if it passed. In the previous mask mandate that we had from Panhandle Health, largely our response to that was education. We were just informing people that there was a mask mandate and the importance of wearing a mask, and as a result, 0 citations were issued. Although we still had a number of calls that came into our dispatch center. I believe last count we had over 200 that came in, both people complaining about it and questions about it and that sort of thing. We didn't have any citations that were issued. I would tell you that we're in a different situation now than we were then. I think most people have their minds made up as to whether or not they're going to wear a mask. And so my big question today is, if this passes, what is the will of council? Do you want us to enforce this by issuing citations, or would you prefer that we just still continue to warn people about it? Because I would tell you that there's obviously, you can hear some people who are not going to comply, and we will come in contact with those individuals. So is council comfortable with us issuing citations to those individuals? That's really the big question that law enforcement has. We're just looking for a clear direction. What is the will of council? And then we will do what the council desires.
So Chief, I'll just give you my 2 cents worth. I still favor the education piece of telling people that there is a mask mandate in place. I think we're going to have to look to some of these businesses that we know that don't have their employees in masks. That again, we're going to educate, and we're going to look. In my mind, we're going to look to egregious offenders, people that maybe you've issued 1 or 2 or 3 warnings to, that they're just not going to comply. Then that's when a citation situation would come in. The way that I see it, and you mentioned it, there are going to be some people that absolutely just aren't going to do it, right? But there are people on the other side that are going to do it. But we have 2 states on either side of us that have statewide mask mandates. So if we have a mandate in place, there are going to be the residents of Coeur d'Alene that are going to do it. There are going to be some that refuse, right? But if we can get the people that are used to, from Washington, Montana, wherever they come from, used to a mask mandate, if they know that we have a mandate here too, they're going to put on a mask. I believe that. I see it. I see it every single day. If people come here from Washington, Montana, or wherever, and they know that they're just not. So with some type of mandate, we are going to get more masking. It's not going to be perfect. It's not going to be everyone. And it's not our intention to give tickets or to arrest anyone. Arresting anyone is not going to happen in the city of Coeur d'Alene for not wearing a mask. It's just not going to happen. So Christy, go ahead.
Thank you, Mr. Mayor. Well, Chief, I have a couple of thoughts on this. Having worked with you, alongside you, responded to numerous kind of calls that were city ordinance violations. I think officers are always, number one, I know what I know about you and how you run your agency. We're always going to prioritize calls. You always will. If anybody out there is thinking if we pass this ordinance that you are going to start calling 911 on your neighbor who's out in the driveway talking to another neighbor without a mask, don't do it. That's ridiculous. You overrun our resources. And officers aren't going to make those a priority call. They just can't. They won't. What we normally do with city ordinances, whether it is fireworks calls that usually start about second week of June and go until the last week, second week of July, people are trying to get some sleep at night and other people are shooting off bottle rockets and stuff all over the neighborhood. We respond as we can. The chief has always had his personnel take the calls as they can. But if they get a particular call and they're down at the city beach and somebody's shooting bottle rockets into a crowd, that's the egregious offense the mayor's talking about. You should expect a citation for something like that. And so I look at that level of discretion with these city ordinances. I know that officers do everything they can to get people to comply. They will ask them, they'll give warnings, but in the end, there is a remedy if they don't get that compliance, and that remedy is a citation. So my expectation is you would use the same discretion you do with every other city ordinance, and if you need to issue citations, you will.
I guess part of that is kind of where the difficulty lies in our job. So I'm just going to use this as an example because it's one of the most glaring for law enforcement. So the bars at night, they are packed with people, not only on the dance floor, shoulder to shoulder, but also waiting in line for some period of time to get in there. We get calls there every single night, and we witness things. Is it the intent of council that if we witness that sort of thing, do we issue those individuals, we're going to go give a couple hundred cites?
I say very possibly. Very possibly you could. You might get compliance as well.
Dan.
Thank you, Mr. Mayor. So this is where this topic escapes from the clutches of science and moves into the playground of politics. So we're done with science now. And we're talking about enforcement. And we had a conversation before here. If council really wants to take this seriously, and I think there are people up here who do, then mandatory enforcement, I mean ranked enforcement above seatbelt laws, above barking dogs, is that the kind of answer you need?
Well, for call prioritization, we're still obviously going to go to something where someone is, currently being injured or an accident with injuries or domestic violence call in progress or that sort of thing. But still, there are going to be those times when we receive reports or we are on the scene of a different type of call and someone says, I want to complain about those individuals over there who are not wearing masks or not following the mask mandate. Officer, do something about it. And once again, since this is a highly politically charged issue, I would just like a little help in the hot seat. Is it the will of council then? Do we issue those individual cites or we go kind of to where we were previously and just say, now you guys need to wear masks and we're going to get some people who are going to immediately offer a medical excuse and some people who are just going to tell us to go away. Should we cite those individuals or leave?
Okay, so how many calls have you gotten in the past few months about mask violations? Any?
No, it kind of went away after. So after the mask mandate was passed, like I said, we received about 200 calls in a very short period of time. And then after that, they largely died off. We would still receive them occasionally. We would respond, and oftentimes the call was prioritized. And so someone was calling saying there was a lady running around store X without a mask on. I want to complain about it because she refused to put a mask on. Oftentimes, by the time we got there, that person was gone. Or what happened a lot of times is we would contact an individual and they would say they had a qualifying medical condition. And so the conversation was basically over at that point.
So would your expectation be that calls will increase tomorrow if this thing passes?
I would expect that, yes, sir.
And regarding the medical thing, the way it's currently written, officers would have to demand proof of a medical condition.
I don't believe that's the intent. I think the intent is that it is a defense to this and they can bring that information into court. I didn't write the ordinance, but I'd rather defer to our legal folks in there. But I guess the way I interpret this is If we receive information that somebody has a qualifying medical condition, then we would use our discretion to not issue that citation. Or conversely, if someone wants to bring that information into court or the prosecutor's office sometime subsequent to the issuance of the citation, then that would be a defense.
If this is to be effective, the enforcement would have to be pretty hard, wouldn't it? I mean, is that, because that's the way it works for most things. DUIs, someone gets pulled over drunk driving, they're going to jail. This kind of thing, if the public needs to take it seriously, enforcement is a major part of that. And I think what you're asking us is, how far up the thermometer do we want to go on enforcement? The mayor mentioned educational, which I think is what we're doing now. But I'm getting the impression that people want you to go farther and you want to know what that limit is.
Well, that's the second part of that is absolutely correct. I'm looking for some guidance here. To be clear, there are a number of laws on the books that we don't typically spend a lot of time enforcing. There are still laws against adultery, for instance, and things like that. We just don't. We don't do those sorts of things, generally speaking. However, these are different times. They're challenging times. And so what I'm looking for the 92 officers in uniform that work for me, what is the will of council? How would you like us to act? And we will certainly follow your lead.
Mayor Whitmire. Yes. Could I just add something, a little bit of clarification? What has been proposed in the resolution that's before council for deliberation consideration? The penalty is an infraction. So under an infraction, no one will be arrested. You cannot be arrested for an infraction. And so it is a penalty. In this case, it was proposed $100. That's the only, that's the penalty, the sanction for violating it. Wes is here. He can talk a little bit about how, if somebody's given a citation, how that would go through the system and how it would be dealt with in our prosecutor's office, if you'd like to hear that.
Yeah. And then Dan, just to add on that medical one, I would anticipate there's going to be some adjustments to that. I'm not in agreement that I think that if, in my own opinion, I may not get a chance to vote, but if someone gives a medical reason, I don't think we have to have them give further proof before we assert.
And to be clear, we would not ask for that proof. We're not doctors. If someone says that they have a medical condition, we will take them at their word. I don't know what a qualifying medical condition is. I have a rough idea because I've done some research and I've listened to some experts to tell us that things like anxiety and PTSD and certain, pulmonary disorders and things like that may qualify, but I'm not that guy. And I don't expect our officers to make that judgment either.
Chief, my understanding was different on that medical condition thing, that it wouldn't be a decision-making piece for law enforcement. So I hope that that's not the case, that it happens in the court level. But my question to you was, when you have officers now who are enforcing city ordinances, is it up to their discretion whether they want to give the individual a warning, like a warning ticket, or an actual ticket infraction? How does that work?
Yeah, so there is some degree of discretion afforded to the officers. Typically speaking, we would go out there and ask the person to comply, as Councilmember Wood spoke about earlier, ask them to comply. And if they were absolutely refusing to comply, then at some point there might be some enforcement that takes place in terms of a citation or maybe a summons to court or something of that nature.
So following up on your bars and nightclubs thing where you have these issues, it would be in the purview of the officer to go into a bar and say, make them aware by virtue of giving them a verbal warning that there is now potentially an ordinance in place whereby every one of their patrons can be ticketed for not wearing a mask. So that would be something your officers would do?
That is a very real possibility. Remember, this was in place previously and we still had bars that were not complying, and I cannot express to you adequately, I think, how problematic it's become with the number of people that have come over from our neighbors to the west and caused a whole host of issues for us. Look, before it just used to be some people that want to go out and have a good time, we have hardcore gangsters downtown now that are coming over here to hang out in our bars because we're open till 2 a.m. and they close at 10. I would tell you that I could see a point where officers are down there dealing with some of the more interesting people that we've dealt with over the past little bit, and they break out a ticket book to solve an issue.
Okay. And then this stage 3 again, we don't know how that's going to affect the nightclub scene. I recall that there was some closures or limitations of number of people, but I don't have that. So that could affect this conversation as well. So thanks.
Any other questions for Chief Woody?
So I understand your dilemma. It's been bothering me trying to understand how that works. Doesn't make sense. You could walk into the Iron Horse and issue 100 citations. I can't fathom it, but I get it. I guess my question would be, and maybe to this whole resolution, is the business owner, the operator, is responsible for who? His customers, his crew, his staff, and then the other question is inside or outside. So outside, people are saying, well, you don't have to wear a mask outside, but you have to wear it on the inside. So that's kind of for you guys to think about, because I don't know where we're going. I read this, it doesn't quite.
I think inside or outside, if you can't maintain the 6-foot social distancing, that's where the mask would come. I mean, you can be outside face to face, 3 feet away from someone, and just because you're outside, that doesn't mean that you can't transmit it.
Okay.
So
the other one is a lot of restaurants and bars, where my world is you're saying that I am now responsible that every to my bar has to wear a mask.
Restaurants have an exception to, and maybe what we're getting into now is that maybe Wes needs to come up and explain.
Yeah, I
that.
was just trying to help him kind of understand how deep do they go. We have put a policeman at every door, makes it real easy. You don't get in if you don't have a mask on. That doesn't make a whole lot of sense to me. But I hear your dilemma, Chief, and hopefully we can figure it out. Thank you.
And just
Let's see if I could add some thoughts.
for this meeting and this discussion right here, is there a plan in place to put forth from staff to Chief to say this is what council wants, or is it just going to be verbally what we bring up today?
No, we will make a decision and we will put bullet points into the resolution.
Add to it. Okay.
And
Councilman English has a question.
Chief White and his folks and between legal staff, they will put that together and what that's going to be. Renata, did we have?
Yes, it appears Councilman English over Zoom would like to chime in.
Okay, go ahead, Dan.
Yes, can you hear me okay?
Yes, we can.
Okay, well, and that just by quick way of explanation, had a trip, long planned traveling today, so that's why I'm Zooming rather than be there in person, but this is so important. Wanted to do this. The law enforcement aspect is certainly an important part of it. I've been on record before as, I don't believe we should pass laws that we don't intend to enforce. So if it was something where, oh no, we're going to have it on there, but we don't really mean it, that's crazy. But at the same time, what I see is, this is a new thing. It is, frankly, the biggest community, area of interest that I've ever seen, intense, emotions and thoughts on this. So we're all learning as we go. But what I would say, if we pass this, then yes, the first line of defense is the education. And just like we did with, parking and other things, of course, they're going to get a warning. But then if it really, gets out of line, then we need to up the ante. However, again, the bottom line is nobody's ever going to get arrested. It's not a criminal case. It's a civil, an infraction. And and that is, of course, for police, that's part of the tricky nature of, discretion and somewhere along the line that it falls. So I guess my sense is, yeah, this is important. We need to show we take it important, but we're not going to go, overboard draconian. And I will be interested to hear exactly what that going back to level 3 means. It seems to me like in the early part of things, when we did have a statewide shutdown, that did include the bars, which would, for now eliminate part of that issue. But anyway, I just wanted to add some thoughts.
and I'm just going off of memory here, I think that stage 3 does allow bars to open. It has some restrictions on nightclubs. So you would have to define the difference between a bar and a nightclub. So there's another thing for us to.
And Mr. Mayor, just to be clear, and I hope I didn't give the wrong impression here. There is a whole group of society that will absolutely comply just by us passing this mask mandate. Just like some people don't smoke on the beach, or when we tell them, hey, there's no smoking on the beach, they put it out. There is a large number of people who will do that. However, obviously there are some people who won't as well. And I just wanted to get some direction there. So I hope I didn't make it sound like we are never gonna be able to enforce this, or it's one or the other. It's either everyone gets a ticket or nobody gets a ticket. That's not it at all. I'm just looking for some guidance.
Yeah, thank you, Mr. Mayor. Chief, do you have proper guidance from council or do you need more input?
We're still a little bit gray. I would if the ordinance passes, some little clearer direction might help a bit, but I think I understand where we're coming from.
So you're good. I mean, do you want us to run through some scenarios perhaps?
I don't know if we need to get that far in the weeds. I think council realizes though that if this passes, you can expect some citations to be written. And there will be some, I mean, look, we're going to be the bad guys in this, the police department. They're going to be mad at us over this. And we're fine with that. I just want to make sure that everybody understands that. When it's in the paper that we wrote X amount of citations last week at Pickup Place because people were not complying with this after a warning, that is a very, very likely scenario on this go around.
I wish people would focus their anger on the policymakers as opposed to the person delivering
Me too.
the bad news.
Mayor Whitmer?
Yes.
Could I comment? Woody, I think, had a question. I just want to clarify that this is an individual, or the draft resolution is an individual mask mandate. So your business would not be responsible for a patron or anybody else that came in for not wearing a mask. Now, there might be other liability for you for not taking precautions to protect your employees or whoever. And you can certainly have your own rules for your own business, no shirt, no shoes, no service, whatever it is. But this resolution would not cause business owners to be cited for people not wearing masks. It's an individual mask mandate. Just want to make sure that was clear.
Okay.
It's been quite the question out there.
All right, thank you, Chief.
Thank you.
Wes, if you could come up and maybe just guide us through a little bit of the resolution. Or if everyone's read the resolution, maybe if someone has specific questions. I'll just throw out a couple of things that I would like to see if anyone gets a head nod. As far as the exceptions, I would like to see that be 10 or under. I've seen it in other ones before, so I just want to throw out that idea. In this draft, it was under 5, but I would say children 10 or under. And then on Part B, as far as the medical issue, I would have the first line, persons who cannot medically tolerate wearing a face mask would be an exception, and I would strike the balance of it. So those, just to kick off where I'm coming from, I would put that out there, and I'd look for council members to ask Wes questions.
Mr. Mayor,
Yes.
and there was one more amendment that came today from Mr. Goodley's office that I think is appropriate, and he provided the language for that. Mike, maybe you could go through that language? Or Wes, I'm sorry.
Is that B?
Yeah, that was Wes, I think, looked through that. He can go for.
So it applies to exception B. If you just want to follow along, I'll read to you as it would otherwise read.
Wes, isn't it section 1, a definition of face covering?
Yeah, I think that's the one. I think
I
it was
apologize.
section 1,
Yes.
yeah.
Every person shall, when in any indoor or outdoor public place, wear a face covering that completely covers the nose or mouth. That can include a disposable face mask, a disposable or reusable cloth mask or covering, or a surgical mask or a face shield, except as herein provided. And what that creates, in that language, what that creates is that helps law enforcement
I can't wear a cloth face mask. Then you need to have a shield. Nobody gets exempted because the shield isn't going to affect and restrict the breathing that legitimate or non-legitimate claims will be.
And which scientists did you discuss to make this change?
They didn't discuss anything with the scientists.
So I had read that the CDC said face masks are not effective.
That's fine. I'm not here to talk about CDC findings.
So this is all for show.
That is for you to make the determination, sir. We were requested to put together something for you that might be workable in this community. That is what we have done. And that's part of what this discussion is what would you like to see in this resolution if that's what you want to do?
Can you read the list again?
I'll be more than happy to.
The change says wear a disposable or
A disposable face mask or a disposable or reusable cloth mask or covering, a surgical mask, or a face shield.
So I guess, Wes, as we get down on the exceptions, if you are outdoors and you can maintain social distancing, that's 6 feet, you are not required to wear a face mask.
That's correct.
Even if you're indoors and you can have the 6 feet social distancing, you are not required to wear a mask. Those are exceptions.
That's correct.
Okay, all right. Amy.
Well, Mr. Mayor, you queued that up perfectly for me. So my question is on section 3, the exceptions H. And as it reads, it says indoor recreational facilities, examples of gyms and fitness facilities where people can employ social distancing as recommended by CDC, which we just mentioned was 6 feet. Is there a way, the recreational, it's stated as recreational facilities, should we say indoor facilities and strike recreational?
I would be, if we're trying to create a document, I think that's.
Okay.
I'll get ahead and nod.
I would make that recommendation.
Okay, we'll make that in there. Dan?
So thank you, Mr. Mayor. Another question for you, theoretically speaking. Today's election day, and my opponents see my supporters showing up at the polls and decide to call the police because none of them are wearing a mask. Is there an exemption for a polling place?
There is not.
Okay. No exemption for a polling place, but yet the state of Idaho mandates that polling places be open to the public. Is this just one of those things where two laws rub against each other?
Give it to me in the context of the way it's written.
So basically, if I don't wear a mask on Tuesday, I can't vote in this country. How's that not disenfranchisement?
We can add that.
Is that the intent?
We can add that to I mean, this is a work in progress, this document. But we can
I
add
have a
that.
different term for it, but we can call
What's
it
that?
work in
What's
progress.
the term?
It's embarrassing.
No, well,
Mayor
that's one
Whitmire,
thing.
there are rules. As far as I know, you can't show up nude at a voting place either, but there are alternatives. You can vote absentee, you can do other ways. So
I just want to know if
it's part of
anyone's
an
going to be written a
accommodation.
citation for standing in line and voting without a mask. I mean, because to me, that would be great television.
I would venture to say, Dan, no, they would not be. Yeah, so Chief is saying no. We could go through a lot of hypotheticals, but we'd be here till midnight.
This was just a question that was submitted to me that I'm passing along.
Other questions? So we do have, I just threw out those on A and B. And then Amy put that one just to strike recreation facilities and have indoor. Anyone else, as we're working towards the potential document, have any other things?
I think, Mr. Mayor, if I could just have a little clarification on your thoughts on B. Clearly, we're still, the intent is if people cannot medically tolerate it, we make an exception for that. I think that's the intent of this. But at the same time, we have to probably have some wording that Wes can work with if people are issued a citation and it were to ever go to court. So Wes, what are your thoughts on B?
I think it's an affirmative defense if they're able to provide some kind of document that shows they have, at the time they receive the citation, something that would give them that exception.
Yeah.
This is very similar to if you get caught driving your car without a driver's license physically on you, it's required. But if you take your driver's license down to court and show, oh, it was valid on the date that you got the ticket, boom, it's dismissed.
Yeah.
You don't even have to see the judge. They do that at the counter. It's the same with no insurance if it's an infraction. You don't have your insurance with you, you're supposed to, but you're gonna get a ticket, but you can go down to the court, show them that you had valid insurance on the date that you got the ticket, it's dismissed.
Do we need to address that in the language, or are you fine with the persons who cannot medically tolerate wearing face covering? And that's it, period.
That's it, period, really.
Okay.
The reality is most individuals, and we deal with this every day in my office, communicating with medical professionals, counselors, psychologists, treatment facilities. We get documents all the time saying so-and-so is compliant, so-and-so had this, so-and-so had that. We don't need to get into their detailed medical history. And these providers are used to providing those simple kind of letters, and they come from nurse practitioners, office managers, doctors, physicians, counselors.
Okay, thank you.
I guess I would just add, it's kind of my 2 cents is that this is not a road that we want to go down.
Right.
I would say if someone is approached, if it's first given education, which is we're starting off with education, but if they say that I have a medical condition, I don't think, in my opinion, I don't think you go beyond that.
Yeah.
That's just my 2 cents. Other questions or other changes?
Mr. Mayor, section 7. This is meant, if this is passed, it's meant to be a temporary ordinance. And I've kind of already talked about that earlier. It's not like every other city ordinance that is baked in from now on. And so at some point we will want to come back, revisit and discuss this. I think 30 days is a little soon. I would ask for 90 days at least. And then we would have time to really assess it, determine if we think it's necessary to continue. Council opinion on that?
I agree with that.
I thought about that time limit as well, but I think this is changing so rapidly, and I think some of our health experts said that we haven't even hit our cold and flu season yet. So I'm wondering if we can put something in there unless there's a circumstance that would require us to take a look at it again. And I'm not sure what that would be, but rather than change it from 30 to a full 90, where would that put us? A full 90 would put us at end of December? January.
And I think we could write it however we want. We could choose to revisit. I just am throwing 90 days out because of just the way that we've heard from the experts on how COVID works and manifests.
I suppose if it was 90 days, but one or more council members brought it forward to agenda, we could we could just bring it forward that way. Okay, I'm good with that.
Any other input on that portion of it? So
I guess I would split the difference and for this first time go for 60.
Dan English, Christie's recommendation was 90 days.
Right, and and originally had 30, and that's what I was saying. I would suggest for this first time 60 would give kind of an in-between, and sounds like that would be about the end of the year, but I think for this point, well, 90 seems a little long, although again, we could come back and alter it, but anyway, that's my thought.
I think that's what Kiki's point was, is we could put 90, but we could, any council person could come back and ask for that to be revisited. So we had the section number 1 that was changed. I had thrown out children 10 or under is an exception. Item B was changed to just persons who cannot medically tolerate wearing a face covering, with the rest being stricken. Yes.
Ask clarification on B. You want to add in there that proof is not required, like many other orders or rules have.
I would like to. I would look to other council members to see.
I think we might,
I'm sorry, go ahead.
sorry, I think we might want to think about that. And the reason is if proof is voluntarily provided at the time, it would negate an infraction from occurring at all. But if the person said, I don't have that kind of proof, they have the ability to bring it back to Wes's office later and the ticket will be thrown out.
What kind of proof are you talking about?
If someone can voluntarily want to say they have a medical condition and they feel comfortable.
Medical papers. So do you have your medical papers on you?
I'm not going to go down that road with you, Dan, and I know where you're going. But a person who is willing and wanting to be in compliant with it and feels comfortable providing that paperwork to an officer, they should have the ability to do so to avoid an infraction. If they don't want to do that,
how do you not see that's exactly asking someone for their papers?
Excuse me, I'm talking.
Your medical documentation.
I'm talking.
And let's let Kiki finish, please.
If the person wants to do that voluntarily, if they don't, our law enforcement has asked us for clear direction. Do we give them a ticket or do we not? They can give them a warning, or they have the ability to give them a ticket and that person can provide that paperwork to the office just like wherever it may come from. And Wes has stated that that happens all the time. So it shouldn't be a huge new process or a burden on the office, and then that ticket will be thrown out. So I just feel like that otherwise you've just created something that everyone can say, I have a medical condition, and we're right back where we started.
Yeah, and I get where you're coming from there, Kiki. I just think that by asking for any type of proof is going to be quite a burden on enforcement. It really is. And I know that there are people that are just not going to tell the truth, right? And I think that's something that we have to deal with. My intent was that if an officer addresses someone and they claim that they have a medical condition, that's going to kind of be on the honor system. I don't know any other way to do that without opening up a giant can of worms.
Thank you, Mr. Mayor. And I agree with your scenario, even though I know your intent, Kiki. Just as Wes started speaking about, if you don't have your driver's license on your person, it's written into the statute, you shall carry your driver's license on your person. But it isn't written into the statute that if you want to go get it later and show it to us, I mean, that we don't need to do that. Wes can handle that on his end at the prosecutor's office. We don't have to, I don't think we need to create language that you can show your medical proof if you want to. I don't think we even need to address it.
But what we're saying is we aren't going to
If I
issue
may,
an infraction.
I actually took the language right out of the license statute.
Exactly. So they still have the ability, if they receive a citation, they want their day in court, they can work through Wes's office or however they want to do. But we don't need to put it in our language asking them, you want to show your medical.
Okay, well then maybe I didn't understand, because I thought what the mayor said was it would be that if they said I have a medical condition, they aren't going to receive an infraction, period.
Well, that's going to be officer's discretion, and most likely they won't.
That was my intent, that it's simply a question. I think Woody and I deal with this in the restaurant business, that if someone has a service dog and they come in and they say they have a service dog, they come in with their service dog. We don't ask for any papers or anything like that. We accept the fact that, okay, you say it's a service dog, come on in. What is that? That's kind of how we do it.
Okay.
Always making deals.
Yeah.
A couple comments if I could.
Go ahead, Wood.
So we just went from 30 to 90 days, but none of that information came from the medical people. That was just us going, well, longer is better. We get a better feel for how it's going to work or how much money we make. Is that the impression I got, or did I miss something? Okay.
No, this is not a money-making thing.
Oh yeah, it's $100.
No, it's not.
It's $100.
So I'm going to push back on that. Okay. The city has no intent of trying to make money off of sick people.
Okay.
The longer period that I've proposed is so we can get a better understanding if the mandate is working. If it's not working, we can come back in 90 days, any council person, and say, you know what, we tried it. we don't think it's working. Or we can say, okay, it's slowing the curve. We're doing the right thing. 30 days, in my mind, is way too short of a turnaround.
But we're judging, that's what I'm saying. So we're going to make the decision whether the curve has gone the direction we want it to be.
We can rely on Panhandle Health.
Okay, but they're not giving us any input on 90 days.
No,
are they?
I
Okay.
threw that out there, Woody, listening to
No
the
problem.
experts.
Can we hear
The other one I had was the impacts on schools. I know the school board's looking at us, the world's looking at us, and I'm wondering, all of Coeur d'Alene schools are not in the city of Coeur d'Alene. So will that impact them differently if they're in Hayden?
Coeur d'Alene School District makes their own rules, right? Just like NIC makes their rules.
Right.
Okay, so we have no impact on them
On the,
or
on them.
the curve because they have kids and are they doing masks or not? You follow, it's kind of like we seem to be the catcher of everybody's doings. We say the rule and some people do, some people don't. And then we, at the end of it, say, okay, we're doing a good job or we're not. Is that how I'm sorry, I'm struggling here.
Well, we're all struggling. We shouldn't be put in this spot, but we are, right? We're not healthcare experts.
We did put ourselves in this spot.
Well, yeah, but it could have been handled and it should have been handled elsewhere.
Agree 100%.
Yeah. So
following up to Woody's question, it was about the 10-year-old, the 10-year-old window, and what we're saying here is that children under the age of 10, but the school district can make their own rules why those children between 5 and 10 are at school.
they can make their own rules in their own building. John, did you want to come up and?
I make a suggestion.
Yes.
Sorry.
We can use all the suggestions.
So you're absolutely right that this is fluid and there are a lot of unknowns. So we just accept that. And your conversation about a 90-day temporary period seems very reasonable. If you wanted to invite Panhandle Health District and Kootenai Health back to a meeting in the middle of December, we can give you an update on where things stand so that the next decision is based on medical information. We would be happy to do that.
Okay, great. Thank you. So there we are with some adjustments that we had made to that. Mike.
Well, Randy just pointed out that we have in the definition, it includes educational, so public place includes educational. Because of the school district and NIC doing their own separate protocols, we might want to take educational out of that.
I would be agreeable to strike educational. Where is that at, Mike?
Section 2.
Section 2 definition.
So section 2, we would strike.
Third line, section 2.
Purpose of showing.
So basically, you could be as an individual in those places and not be cited for not wearing a mask, but I assume you're going to be complying with the rules that the school district or NIC sets to be in that place.
So we would strike educational. Okay. Renata, have you captured those?
It's between Randy and I. We will have them.
Okay, all right. So we have that, if someone is looking to make a motion.
Mr. Mayor, I'd like to just have the floor for one
Yes.
quick minute. So, unfortunately, it's well on us to make a decision about a temporary mask mandate. I've reviewed the data and the information. I've read every single one of the 1,000+ letters and emails sent to me this weekend. I truly appreciate all the time people took to reach out to all of us. First, there's overwhelming scientific evidence supporting mask wearing, physical distancing, hand washing, and staying home when sick as effective measures to slow transmission of coronavirus. Wearing a mask not only protects you, but also it protects everyone around you, your family, your friends, your colleagues, and your neighbors. Second, we are at dangerously high levels of transmission in our community. We're near flu season. It's cold out, more people will be indoors and physical distancing is more difficult. Third, our hospital, Kootenai Medical Center, is near capacity and the situation there is critical. Our physicians, nurses, first responders, and healthcare professionals are asking for our help. Fourth, our schools, colleges, and universities are unable to open normally and function as they normally would. They are begging us to help protect our students, teachers, the school district staff, and their families. And finally, our businesses have been so greatly impacted by coronavirus. We can't afford another business shutdown. We are a community with a deep, rich history of unity to overcome adversity. We join resources and we stand against challenges. And being brave and holding steady in the eye of the storm. I'm proud of Coeur d'Alene and I'm proud of all the work we've done to fight COVID to this point. However, we're not done and we haven't yet won. I work daily, along with everyone else up at this table, to keep our community safe and protect the lives of our citizens. I will continue to do so by voting yes for the mask mandate.
So if we could have someone put a motion, or we can have further discussion.
Oh, go ahead. I can do it if you want. I don't care.
Happy to. Mr. Mayor, I'll make a motion to approve resolution number 20-059, requiring the use of face coverings in indoor and outdoor public places with exceptions, and updates to section 1, 2, 3, and under section 3A, B, and H, and section 7 to help reduce the person-to-person transmission of COVID-19.
I'll second that. You
Have
did
a
much better than me. I did.
and seconded by Christie. Further discussion by council?
Let's see, this is Dan. Can you still hear me?
Dan?
Okay. For some reason, I've lost the video, but if you can hear me, I just wanted to add, I realize this is a very high impact decision that once in a while we get called upon, but I have to say for me, it's an easy decision. I'm going to support this, and I frankly don't give a second thought to that, because I'm just convinced this is what we need to do. I'm sorry some don't agree, but I'm willing to pay whatever price they think I need to pay, but I'm supportive.
Thank you, Dan. Kiki.
I just wanted to mention, because I don't think it got brought up in this conversation, that I received a letter in support of this temporary face covering mandate from the Coeur d'Alene tribe, from Panhandle Health, and also a letter that had 15 regional CEOs who were in support and of healthcare providing entities that were in support of us doing what we could to initiate face covering within our jurisdiction. So I wanted to make sure that was mentioned.
Thank you, Kiki. I wanted to just throw out a couple of things, is that this is a medical issue. I think that we all rely on people that we trust for our medical decisions. And I can't think of a better group to trust with our health than Kootenai Health. And here is a letter that is signed by 281 Kootenai Health doctors, and I'll just read some highlights here. It says, "We, your community physicians, ask you to help us protect the very people that we have pledged to serve. The past 7 months have been exhausting, but it now appears that the battle is just beginning. The surge in COVID-19 cases that we've seen locally in the past 7 days exceeds the first uptick that we experienced in July and does not appear to be slowing. Recent unprecedented hospital admissions, both for COVID-19 and other illnesses, has forced the Kootenai Health to enact aggressive measures to meet the demand for healthcare in our region." This is a really critical statement here. It says, "We are at a tipping point, and we are already unable to fully respond to the needs of our community." They close here by saying 7 months of worldwide experience and numerous well-designed evidence-based scientific studies have demonstrated that without a question, masks and social distancing slow the spread of COVID-19. We urge you to support and enforce a mask mandate in the city of Coeur d'Alene for the health and well-being of all the people that you represent, signed by 281 Kootenai Health doctors. A couple other things that I wanted to add is that way back in July, when we had this surge, and it was 323 cases the week of July 13th, we were all concerned. At that time, I said that I was not in favor of a city of Coeur d'Alene mandate because I didn't think that was the right way to do it. I thought we needed a Kootenai County mandate, and that still is the best way. City of Coeur d'Alene going it alone is not the best way to do it because Kootenai Health is going to get patients from throughout the county and really throughout the region. But this right before us is the best that we can do. And for me, doing nothing is not an option. So there's going to be some people out there that are going to say, oh, Widmeyer went against his word because he said he would never mandate. Situations change, and we're in a much different situation 3.5 months down the road where we are today, and we're in a critical situation right now. And I want to read something that we got late today in an email, and I don't know if the council members got it, but this hits a little bit home for the city of Coeur d'Alene, and it comes from Marla Lake. Marla is, as those of you know, she supervises the Jewett House for us, has been there for years and years. And here is what Marla sent in her email. She said that the subject line here is, Mom just died of COVID. Dear Mayor and City Council, please initiate a city mask mandate with consequences for noncompliance. I've been a registered nurse for 25 years, having spent my 15 years as a critical care nurse at Kootenai Health and now as a hospice nurse. I just spent 3 days on FaceTime holding vigil with my mom, who is dying from complications from COVID. No one should have to die from this disease or have to die without family by their side. Science is proving that areas where stricter mask mandates are in place slow infection rates. Although we have had many healthcare workers get COVID, wearing masks must be helping. Otherwise, I think we would be seeing exponentially higher numbers of healthcare workers getting the infection. The culture in our country is deeply divided over the issues, and I respect every one of these people outside this door and their opinion. I don't discount their opinion whatsoever. I may disagree with it, but I don't discount it. So that these are difficult decisions, but I believe it's time for sacrifice. Thank you for your time and all your hard work through this virus. So that comes from Marla Lake. Dan.
Thank you, Mr. Mayor. So I don't need to tell everyone that I'm going to be voting against this. As a representative in this country, I feel my first duty as an elected official is to protect your rights. We have the Bill of Rights. We don't have the Bill of Feelings. And I know that's really tough. There are certain risks we have to take to live in a free society. And I believe it's up to the individual to gauge those risks. I don't think masks work. I really don't. There have been mandates in other countries like France and Italy, and their numbers are going up. Now you can argue, oh, well, that's because people aren't complying. And I can argue that's because masks don't work. We have experts here that came and talked to us just earlier, and they don't understand how this virus works. No one does. Therefore, my opinion is that a mask is a mere placebo, especially given that the CDC originally said no. And then they said, well, you know, if you really want to block a virus, you have to use an N95 mask. That's most effective. These cloth masks are basically fashion accessories. They're not helping you, especially given that we have no data on how the thing works. We don't know why it'll go into a place and it'll literally kill one person and the rest of the people never get it. How can you fight something that you don't understand? And I think that there's going to be massive civil disobedience. It's going to put our cops in a really awkward situation. And even though the chief, I think he was polite, I don't think that direction has been given on this, because if you people were really serious, first of all, you'd mandate N95 masks. You would mandate a proper disposal method for the masks if they are truly contaminated. And you would also mandate that there would be adequate enforcement of this. And you're not. So therefore, this is just a political game, and I will not participate. Thank you.
Christy.
Thank you, Mr. Mayor. Well, Dan, I can respect your decisions and your voice. Fine with that. I'm just not on the same page as you. I echo what the mayor said earlier. The idea of doing nothing is just not acceptable to me. I want to do everything we can to slow the spread. Our first responders are being exposed at alarming rates. Our healthcare workers are begging for our help. As teachers, our first line workers. I want to do everything I can. Doing nothing's not an option. And so I guess we'll just have to agree to disagree, and we'll come back and revisit. The other things you said that we haven't mandated, we can only do what we can do. We deal with what resources we have.
Other discussion? Wood, you got anything to add? I know you're exhausted from it.
Well, you know, I believe in the mask. I have a cool one here from the fire department. We wear shields in the restaurants. We take it seriously. Food business, you have to take everything seriously. Remember back in the days, Laura, when it was food handling and things, and now it's another level. But that's the world that I live in, and Steve has a piece of that too. And a lot of my restaurant folks here in this whole area are kind of in the middle of them. Some have moved on. They've said, heck with the 6 foot, heck with the social distancing, and they're learning some lessons along the way. I've been real fortunate that we've stayed with the 6 feet. We've stayed with the every other table closed, and people are willing to work with us. So I believe in personal responsibility. I believe that businesses, it's your business. If you don't make it work, if your customers aren't comfortable, you don't survive. It's that simple. And you see that happening around. And we can blame people. We can blame all the different things. We take it real seriously. I mean, I just found out that taking our temperature doesn't matter. I have months and months and months of paper of everybody signing in and taking their temperature. And I use both sides of a piece of paper. That's how cheap I am, right? And so now you're telling me I don't. We take all the precautions we can. We clean, we wipe, we sanitize. It's just this new reality is just beating the heck out of us all. And most of my crew is a little older, so the masks affect them. We've tried different shields. We give them that courtesy to try different things so they feel comfortable. Most often, my customers feel comfortable. They're the ones paying the bills. So I am a big supporter of the mask. My concern and my problem is I don't see where us as a city is setting the example. I guess it'd be one way to look at it. I just don't see how that's the best use of what we can do. So I'm not going to support this just based on why the city does it and the county doesn't. And
Wilkins a no and Woody's a no.
So I'm going to take the other way out, and I apologize.
No, I think Keika will vote for it.
The effort and the concern, and I believe in the mass, and I will, and we will keep doing it. So that's kind of my yes, which is a no.
Any further discussion? No further discussion. Roll call, please, Renata.
English,
Yes.
Wood,
Yes.
Evans,
Yes.
Miller,
Yes.
McEvers,
No.
Kuchen.
Absolutely not.
Motion.
He went for it, so it's passing 4-2.
So moved.
Second.
And a second to adjourn. All those in favor?
Aye.
We are adjourned. Thank you, everyone. Appreciate that.